We're going to start off our session today with Dr. Vikas Khitan. Vikas is a professor of ophthalmology at FEI and heads the region's first ocular oncology service. He specializes in treating intraocular tumors, performs pediatric and adult retina care and surgery, and is our primary surgeon for our gene therapies program. Vikas joined FEI after practicing at Sankara Nethralaya, a tertiary eye care center in Chennai, India. He completed his ophthalmology training at Kasturba Medical College, and then went on to complete several fellowships. The first was in ocular oncology. This was done at Toronto's Hospital for Sick Kids and Princess Margaret Hospital for Adult Oncology. He then went on to complete a fellowship in ocular oncology at Wills Eye. Vikas' research interests include retinoblastoma and ocular genetics. He's published over 100 peer-reviewed publications, and we're very much looking forward to his presentation on choroidal melanoma.
Thank you, Ben, for the kind introduction. And I don't like debates. People are fighting, and what's there to fight about? So in this, that's why I invited my very good friend Rajneesh, and we're going to tell you how a team can work together. And special thanks to Mona. Mona helped me put up the slides together. So this was a case referred to me, referred for pigmented lesion. And as you can see, there is some pigmentation that you can see in the angle here. This was an 86-year-old gentleman who was referred for a pigmented lesion on the inferior iris. He was diagnosed to have a pigmented lesion in the right eye. 18 years ago, he was diagnosed to have peripheral exudative hemorrhagic chorioretinopathy and was seen by Dr. James Osberger. He said it was not a melanoma, it's a pseudomelanoma. He advised him to watch that condition. He eventually developed a vitreous hemorrhage for which he underwent a vitrectomy, developed a retinal detachment, had a second surgery, retinal detachment repair with silicone oil, and silicone oil was removed. So when he came to me, his vision was counting fingers at 3 feet and intraocular pressures was 19 in the right eye. And as you can see, there's a lot of stuff that you can see, pigmented lesion in the angle inferiorly and something at the pupillary border as well. And this is what we had intraocularly. So you have a large pigmented mass, and there's another small tumor next to it that's implanted seeds on the retina. But what was worrying for me is that actually you see bare sclera underneath. So there is no choroid, there's no RPE there, and yet he developed a new tumor. And he was being followed by a retina surgeon for 18 years. And the reason for drop in vision was a macular scar. So this is the ultrasound, tumor dimensions. So the height of the tumor is 5.6. So technically speaking, this is an ideal patient for a plaque radiation therapy, all right? Because you can easily plaque the intraocular melanoma. MRI confirming that, a PET scan was performed, which did not reveal any other hypometabolic lesions in any other part of the body. And I advised an enucleation for this patient. And the reason being that this is not a choroidal melanoma alone. There is invasion of the angle. We have a lot of lesions on the angle. We don't know the entire extent of the lesion, and there is no way you can salvage this eye because of angle invasion. So he had an opinion with Dr. Arun Singh, who also agreed with my opinion. Patient underwent enucleation, and the histopathology confirmed choroidal melanoma. And the pathology of this will be shown by Rajneesh after my talk. The second case was referred for black area in vision, and this is a retroillumination. What you can see, the entire lesion above is actually a melanoma. So he was a 59-year-old male. He was a commercial truck driver. Symptoms began 6 months ago, and he began with when he noticed peripheral vision loss 1 month prior to presentation. And at presentation, his vision was still 20/40. And there was a history of skin melanoma in him in the past. And this is what the tumor looked like. You can see the extent of the tumor almost 6 clock hours superiorly reach just you can barely see the nerve and the fovea. And that's the reason the vision is still 20/40 and occupying the entire globe. OCT, the macula is fair, there's no fluid there. This is 2 months later. So he took time to decide, have his MRI, other testing done, came back 2 months later, and now you see that you can't see the disc. The fovea is also bisected by the tumor, and there is inferior exudative retinal detachment. So this is a slide showing the comparison between the two visits. Again, he underwent enucleation and a ball implant was placed, and he's now had a prosthetic shell fitting over the eye. And pathology again will be shown by Rajneesh. Moving on, third case, this was referred for eye pain. And the symptoms were drooping eyelid drooping, pain 1 month prior to presentation. This was a girl who was living in home care, had issues, was mentally retarded. And what you can see here is ectropion UVA, extensive new vessels, hardly any view to the fundus. All you could see was retina right behind the lens. But on ultrasound, we saw a tumor. And she also underwent enucleation because of it being a painful blind eye. So choroidal melanoma is the most common primary intraocular malignancy in adults. It's the second most common type of melanoma after cutaneous melanoma. It arises from neuroectodermal melanocytes within the uveal tissue, and the mortality is about 15%. 50% of patients die because of metastasis if they live long enough, and usually metastasis is seen in almost everybody if they live 10 years or longer. The incidence is about 1.3 to 8.6 per million in the Caucasian population, and it's less frequently seen in the pigmented population. The age is around 5 to 6 decades, median being 55 years, and the incidence rises very rapidly after 70 years of age. There's a slight male preponderance. Most cases are sporadic with no family history. And we did a study in India where we found that the patients at our center presented at least a decade earlier. So we saw melanoma a decade earlier in India. How do we classify these patients? Based on anatomy, they could be classified as having 5% of all melanomas are iris melanomas, 25% ciliary, and 70% are choroidal. And you could have a combination of both ciliary body and choroid being involved. Based on pigmentation, it could be amelanotic, pigmented, or a variable which has a component of both pigmentary and amelanotic part. There are various ways in which people have classified melanoma, beginning with Knapp's classification in 1864, and now we follow the TNM classification for classifying melanomas. COMS was the most popular classification system, and most centers even today follow the COMS because it's much easier to remember. And as per the COMS classification, a small tumor is something that has a largest basal diameter ranging between 5 to 16 and a height of 1 to 3 millimeters. Medium is less than 16, height being 3.1 to 8 millimeters, and large is when you have largest basal diameter of more than 16. And there was a classification system followed up to 1990, and then there was a little small modification made after that. And after 1990, the one in the bottom is what we follow. So here you have a small melanoma, a medium, and these are two large melanomas. Then came the TNM staging system. And the reason this happened was because most of the other tumors in the body are classified based on TNM staging system, which includes tumor, node, and metastasis. And for the last 10, 12 years, Dr. Paul Finger from New York, he's been working on staging every single eye cancer based on the TNM classification system. So the disadvantage of COMS was there was no distinction between a ciliary body lesion, an iris lesion, or a choroidal lesion. It was primarily only for choroidal melanoma. So we could not sub-classify iris or ciliary body lesions. In the TNM staging system, we had a way to divide iris, ciliary body, and the choroidal lesions. And I'm not going to go into details of this, but this is something in evolution. So as they stratify patients under different groups, and they find that there are things that don't go according to classification system, this is something in evolution. So every 2 or 3 years, the classification system is updated. And we're doing so for retinoblastoma as well. Having classified, what are the treatment modalities that we have? So it begins with observation, laser, TTT, PDT, radiotherapy, local resection, and enucleation. Observation is actually used for small tumors where you do periodic fundus photography and ultrasound, and only when one sees an increase in the size is when one treats. So observation is still used for borderline cases where you're not certain about it being a melanoma and there's a doubt between nevi and melanoma. So very often you can observe this, have a documented growth, and then plan your treatment. Laser is almost abandoned now. Nobody does laser for primary melanoma because we know there are chances of recurrence and you're not 100% sure that you've treated the entire tumor, but all of us have done it. So I'm just showing a case that I treated when I was in India. So initially you begin by doing 2 or 3 rows of laser around the tumor to cut off the blood supply to the tumor, and then you go on treating the tumor itself. So this patient responded very well, and you see a very nice scar. TTT again, as a primary modality, it's given up. Nobody does TTT as for primary treatment. It is now used as an adjunct where they do brachytherapy to treat the base of the tumor. And if the tumor is, if you're not able to reach up to the apex, they do TTT on the top. So it's called a sandwich therapy. And like one of my cases where I did TTT and it worked, but most of us have a handful of these cases. What is the most common eye salvage procedure is brachytherapy, where you use a gold plaque with radioactive seeds on it. You sew it onto the sclera and treat the eye for 4 or 5 days, 7 days, depending on the activity of the seeds. And this helps us in saving a lot of eyes with choroidal melanoma. The most common isotope that is used is iodine-125, followed by ruthenium and palladium at some centers. And the indications for plaque radiation are small and medium-sized tumors that are outside the retinal vascular arcades and posterior to the ora serrata, ciliary body melanomas, some large melanomas, and melanoma with a very small extrascleral extension. I did have videos, but they were not playing, so I just removed them from the presentation. I'm happy to say that we are in the process of starting brachytherapy at Flaum very soon, probably in the next month or 2. We should be up and going, and we will start treating these patients with plaque radiation at our institute. The other treatments are charged particle radiation, where you use either proton or helium gamma knife radiation, primarily used for very large tumors that are located in the papillomacular bundle close to the optic nerve, where radiation will cause less damage and you'll have more effective results. There are complications. About 1/4 of eyes that we treat with radiation, any form, and especially brachytherapy, they'll end up developing complications in terms of radiation retinopathy, maculopathy, papillopathy, and we do land up doing secondary enucleations for these eyes because of a painful blind eye that they develop eventually. Surgical excision resection can be done externally or internally, but they are reserved for very, very few selected cases, not routinely performed at all the centers. Enucleation, again, is a very, very good treatment modality. It's done for large tumor size, neovascular glaucoma, when you have optic nerve invasion by the tumor, painful blind eyes, you have localized extracranial extension. When you discuss with patients, they don't want long-term follow-up. Sometimes they opt for enucleation as a treatment modality. And when you have very poor visual potential in an eye that has mixed size tumors. What are the prognostic factors in ocular melanoma? Clinically, they are size of the tumor, location, Ciliary body tumors and proximity to optic nerve, they are poor prognostic markers. Tumor microvasculature, extracellular extension, histopathology, I will leave it to Rajneesh, but there are a lot of things that we look at in histopath, and we can say whether this is a good tumor versus a bad tumor. And nowadays, there's a lot of role that the genetics of the tumor itself plays. So chromosomal alterations in the tumor in the form of monosomy 3 is a bad prognostic marker. Clinical features are older age at presentation, male gender, large tumor basal diameter. These are poor prognostic markers. And histopathology, I will leave it to Rajneesh. In terms of cytogenetic features, it is monosomy 3, chromosome 8p gain or 8p loss, 1p loss, and 6q loss. And based on the gene expression profiling, we now classify tumors into class 1 and class 2, and that is supposed to prognosticate the metastatic potential of a tumor. So to conclude, choroidal melanoma is rare, however deadly intraocular malignancy with a high propensity to systemic metastasis. Prognosis is dismal and metastatic melanoma. So if it is already metastatized into the liver or the lungs, the prognosis is not good because we don't have good treatments for metastatic melanoma. Any pigmented choroidal lesion should be carefully evaluated for possible signs of melanoma or malignant transformation. The combination of early detection, gene expression profiling, and vision sparing treatments have the potential to help patients in earlier treatment process before the tumor metastasizes. And as in anything else, more research is needed so that our patients can have more benefits in the future. Thank you.
Our next speaker is Dr. Rajneesh Bharadwaj. Rajneesh is a clinician scientist in the Department of Pathology. He completed his medical training at the All India Institute of Medical Sciences. After that, he went on to do a PhD at UT Southwestern Medical Center in Dallas. And after a postdoctoral fellowship at Johns Hopkins, he completed his pathology residency and neuropathology fellowship training at the University of Washington. Raj's research interests include the molecular mechanisms that are involved in neurodegenerative diseases, particularly in Parkinson's. He has clinical interests that include an interest in ocular pathology, and that's where we collaborate with him quite a bit as a department. His presentation today will be on the histopathological examination in ocular melanoma.
So thanks a lot to Dr. Ketan for inviting me here, and he has already given a wonderful lecture before me. So I'll be presenting mostly the histopathology, and the three cases that we have are all choroidal melanomas. So here is, he showed this slide earlier. So here is just a TNM classification for choroidal melanoma. It is a little different for the iris melanoma. So there are a lot of factors that are listed here, and I'll talk about some of the most important things that determine the stage of the melanoma. So when you receive a report from us, there is this list, and the things that are most important are the size of the tumor, and there are two factors. There's the greatest basal diameter and greatest thickness of the lesion. And the other important factor is ciliary body involvement. And finally, there is extrascleral extension. And I'll talk about some of the histological features also, which determine the grade of the melanoma. So this is the chart for based on tumor thickness and largest basal diameter. So basically, there is a matrix where you have tumor thickness and largest basal diameter, which determines part of the staging of the neoplasm. And so I'm going to show you these images multiple times. And here is just a whole slide image of a cross section of the eyeball. This is a pupillary optic nerve section. And you can see on the left is the anterior where the cornea is, and on the right there is the posterior. The retina is detached here, that is artifactual here. And the lens can be seen also. So this is just an image and for the whole slide, and then I'll show you the whole slide images of all the three neoplasms. So the first case is JB, and so this is a gross image where we have a section of the eyeball, and you can see that on the left there is the cornea, there is the optic nerve here, and you can see the mass in the periphery. And about the ciliary body or iridocorneal angle, it is a little difficult to tell on the basis of just gross here. But if you look at the whole slide image, you can see the mass here at the bottom. And then if you look at the iridocorneal angle, you can see in blue there is the involvement is there. And then if you look at the other iris also, there is the involvement by the neoplasm. So this is just an image of the low power image of the lesion, and you can see all this brown pigment, and which is the melanin pigment characteristic of melanoma. And top is and then the neoplasm, bottom is the sclera. And here is, first I'll talk about the various areas of involvement. So you can see the iridocorneal angle here. So the iris is on the right-hand top, and the cornea is on the left side. And you can see that it is entirely occupied by the melanoma. And then the ciliary body is also involved by the neoplasm. And this is the other iris, and you can see that that is also involved by the neoplasm. So iridocorneal angle, ciliary bodies, and iris, all three are involved by the lesion. And sometimes it could be a little confusing as to the origin of the neoplasm, whether it is coming from the iris or whether it is actually a choroidal one. And so the basic rule is that if 50%, more than 50% of the neoplasm is in the iris, then you think of it as iris melanoma, and then the staging is done on the basis of iris location. So a few other things. So here you can see that in the pink there is the sclera, and you can see the mass over there. So there are two small masses in there, which are neoplasms. So basically there is intrascleral invasion there. And this is the optic disc and optic nerve. On the right side, you see the anterior aspect of the optic nerve. So that is free of the neoplasm. Now, I'll talk about the histological features here. So first, you can see all these brown cells, the pigmented cells, so which are carrying the melanin pigment, which of course points you in the direction of the melanoma. But then there are amelanotic melanomas also, which I'll talk about later. And there are two kinds of histological patterns based on cellular morphology. There's the epithelioid component, where the cells have a polygonal shape there, and which is demonstrated here. So this is the epithelioid component, which is present here. And the other component is the spindle cell component, where you can see that there are these elongated cells with elongated nuclei, and they're kind of arranged in fascicles, which are intertwined with each other. So the importance of these is that the grading can be based on the spindle cell and epithelioid component. So if the spindle cell component has the best prognosis, graded as grade 1, and if it is purely epithelioid, then it's grade 3, worst prognosis. And most of the cases lie in between, where you have the mixed morphology between the spindle cell and epithelioid component. So this was a mixed morphology. And again, the cytological features, one of the common things that you see observed in melanoma is these cells with very prominent nucleoli, which you can appreciate here. And the cells have large irregular nuclei. So based on these features, we provided a stage where it was B2B, and the size was, greatest diameter was 14 millimeter, thickness was 4 millimeter, and it was a mixed cell melanoma with intrascleral invasion, no extracellular extension. So the next case is GJ. And here, again, this is a gross section of the eyeball. And you can see that there is a large neoplasm centered around the optic disc. And but it doesn't seem to be actually invade into it. And you can see that the retina is detached here. This is a slide image where in dark blue is the mass. And again, you can see that it is close to the optic disc. And this is just a low power view of the lesion, and you can different from the previous case, you can hardly see any melanin here. So this is amelanotic melanoma, and just wanted to show you in a little more detail. So on the top, this is the lesion. Here is the detached, and then there is the detached retina, and it is meeting the optic disc. So you don't see actually invasion of the optic disc or retina by the neoplasm here. This is a higher magnification again of on the similar area. You can see the optic disc and retina. So it doesn't seem to be actually, though neoplasm is closed, the optic disc is not actually invaded by the neoplasm. And the morphology is also different here, because you can see that the entire neoplasm is composed of these spindle cells. These are the elongated cells, again, forming these haphazardly arranged fascicles. And this is, again, a higher magnification of the spindle cells there. Because it was amelanotic, it is sometimes wise to just stain it so that you can confirm the diagnosis of melanoma. So this is a melanate red stain, and that is a marker for melanoma. And it is the red staining that you're seeing is all because of is diagnostic of melanoma. So again, based on these findings, the stage was BT3A, and this is a spindle cell melanoma. So the grade would be grade 1, because more than 90% of the cells have the spindle cell morphology, and tumor involvement was mostly in the choroid and not any other structures. And it is centered around the optic disc. So, and the final case is EF. This is, again, a gross image, and you can see a very large mushroom-shaped neoplasm at the bottom of it. And then on top, you can see the detached retina, which the neoplasm is pushing. And you can also see that it is almost abutting the ciliary body, which will be more clear in the other image. So here is a whole slide image, and you can see in dark blue the mushroom-shaped mass. It is pushing the retina and almost adherent to it, and then it is also very close to the ciliary body anteriorly. So first, let me show you, this is the mass. Here it is, melanin pigments can be seen. So it is not an amelanotic melanoma. And some of the structures that are being involved here. So here you can see the iris. This is the iris, this is the cornea, here is the iridocorneal angle, and this is the ciliary body. And this neoplasm is abutting, and some of it is actually going in the ciliary body. And in the next image, it'll be more obvious that here you can see in the pars plana, it is almost attenuated by the neoplasm. So neoplasm is chewing up the ciliary body here. And the pars plicata is also kind of atrophic, and definitely there is some involvement there too. So ciliary body involvement is there. And this is the retina here, and you can see the retina nicely here. And at this point, it is almost gone here because it's chewed up by the neoplasm. About the histology, it has the spindle cell component, which you can see here, the elongated cells. and it has the epithelioid components also, which is the polygonal cells. So it is again a mixed cell melanoma, which should fall in the grade 2 category. And so based on these features, finally the diagnosis, the stage was T4B, and it is largely because of the size of the lesion, and it was 37 millimeter. And one of the things I would like to point out, because there may be, when you're looking at our reports and there may be some confusion, that the important thing to pay attention to what we're saying as greatest basal diameter, because when you cut the lesion and then you're giving a diameter at the cut section, that is different from what the entire span of the neoplasm is projected on the sclera, because on the cut section, you can cut it in different planes and you get different values. So it was a very large lesion with 37 millimeter basal diameter, and the thickness was very high too, involving choroid, ciliary body, and retina. So stage was PT4B. So that's it. These are the 3 cases. This is how we do the grading, and thank you.
Thank you, Raj. Our next speaker was introduced in the previous session. We have Dr. Wen Hu coming back up. As you'll recall, Wen and Amde went toe-to-toe over steroids. So welcome, Wen. He's going to be talking about approaching HLA-B27 associated uveitis.
Hi, thanks for having me back again in a much more collaborative format. I'm pleased to talk and share this with Anatole Kleiner, my rheumatology colleague, who we share a lot of patients with in our joint uveitis rheumatology clinic that we started this year. So today I'm going to talk to you about a general approach to anterior uveitis with a focus on HLA-B27 associated anterior uveitis. And our objectives are understanding the basic approach, generating a differential diagnosis and initial workup, and then thinking about treatment principles. So number 1 rule of uveitis, well, we'll talk about number 1, number 2 rule. You have to identify the site of inflammation. You can't call it anterior uveitis if there's inflammation anywhere else. And you don't know if it's anterior uveitis unless you if you haven't dilated the patient. So anterior uveitis is classified specifically as iritis, iridocyclitis, or anterior cyclitis. So mostly in the anterior chamber and maybe a little bit of inflammation behind the lens. Intermediate uveitis is if it's predominantly in the vitreous and you're seeing vitreous haze. Posterior uveitis is anything in the retina or choroid actual lesions. Please remember that CME, optic disc edema, retinal vasculitis, those do not count as posterior uveitis. Those are sort of in their own category and often a response to inflammation. Some cautionary tales why we say you have to first look everywhere in the eye before you call it anterior uveitis. This is a 20-something-year-old woman. She was treated for anterior uveitis, was not getting any better, had never been dilated. This is HSV, acute retinal necrosis. This is another patient who I showed you earlier, a 12-year-old with tubulointerstitial nephritis with uveitis. It classically presents as just bilateral anterior uveitis in kids, but you can get fulminant sort of choroidal lesions. She had this very, very difficult, very sort of aggressive kind of uveitis. There was no view because she had syneeked her pupil, but this is what you can get with an Optos. This is helpful for you to know, is this just anterior uveitis? Is there something else? This is a patient who came in for disc edema and was getting a workup for idiopathic intracranial hypertension. And then in the part of her evaluation was noted to have some granulomatous keratic precipitates. And based on history, there was a high suspicion for sarcoidosis. You look in the back and you don't really see much, but it was so suspicious for sarcoidosis, I got a fluorescein angiogram and ICG, and all of a sudden she has all these choroidal lesions. This is no longer anterior uveitis. This is at least anterior uveitis, and posterior uveitis, you might call it panuveitis. And then interestingly, just to tie into our last talk, so one of those patients that we saw the gross specimen of for melanoma was initially referred to me for anterior uveitis. There were pigmented cells in the anterior chamber, often maybe a little bit confusing. You can mistake that. There's no view to the back. We did the B scan, and that's where we found the mass. So in summary, principle one, identify, make sure it's anterior uveitis first. You have to dilate all the patients. And if you can't see it at the back, imaging is helpful. Principle number two, I'm going to sound like a broken record from my last talk. You have to rule out an infection. So any uveitis, we think about big buckets: infectious, inflammatory, masquerade syndromes. I think we have a tendency to jump. If inflammation, it must be inflammatory. Inflammation is just a response. And so the differential, just a limited differential here, syphilis, TB can do anything in the eye. And for anterior uveitis, you can also think about herpetic etiologies, inflammatory HLA-B27, we'll talk a little bit more about, sarcoidosis, we saw an example of TINU, and then JIA-associated anterior uveitis, and then masquerade syndrome. So lymphoma, leukemia can look like inflammation in the anterior chamber. Ocular ischemic syndrome does give you some inflammation in the anterior chamber, but the predominant treatment for that is treating the ischemia, not treating the inflammation. Pigment dispersion can be a masquerade as well. So we'll play a little game here. Residents, get ready. Is this infectious, inflammatory, or masquerade? So how about this one over here? I'm going to call on Alec. Syphilis, great masquerader, also infectious. All right, what about this one over here? Felix. Yes, this is C. acnes endophthalmitis, initially treated as anterior uveitis, got subtenon's triamcinolone, now looks like this. What about this one? Let's go, Ewan, up in the corner. What if I showed you this picture of retroillumination? That is iris depigmentation, yes. But this is actually also infectious. It's herpetic. So you must rule out infection first. Think about infection before you start thinking inflammation. And then I would say sort of my general workup, I sent syphilis and TB on everybody, HLA-B27, and then sarcoid testing. If you're just looking at anterior uveitis, I think this is a good place to start. And then depending on who you talk to, I prefer chest x-ray for screening for sarcoidosis. So let's say you send these tests. The most likely thing that's going to come back positive in your acute anterior uveitis patient is HLA-B27. And depending on the study, it's about a quarter to a third of patients. So what is HLA-B27? We're going to go dive deep back to biology and medical school, but we have these major histone compatibility molecules in our body. They are responsible for presenting antigens to our CD8 T cells to tell you, is this self, is this other, do you need to respond? HLA-B27 encodes some changes in this binding cleft, the antigen binding cleft. And it's thought that based on the way that it presents molecules, it maybe predisposes you more to some of these autoimmune conditions that we'll talk about. That's sort of the big global view. The epidemiology, it's a genetic marker, so it varies depending on the part of the world that you're in. In some places, it's half the people are HLA-B27 positive. Testing for that, probably less useful. Other areas, including in the United States, the prevalence is much lower, less than 10%. I think, your positive predictive value is a little more helpful. Some of the clinical features of HLA-B27 associated anterior uveitis, it presents a little bit younger. There's a male preponderance as opposed to an equal sex in your other anterior uveitis. It's often an acute presentation, often really fast. They start symptoms, they're like, I felt something, and the next morning they're in a full-blown flare. The recurrences on average once a year. And they can get a lot of inflammation, fibrin, hypopyon, and this can be, within hours or 24 hours of symptom onset. And then, as we'll talk about, there's a high association with systemic disease. So principle number 3 is to treat these patients really aggressively with steroids because of the propensity to have such severe flares, because you don't really want to end up like this. This is a patient, this is his right eye, this is his left eye. He has these recurrent flares of HLA-B27, anterior uveitis. These pictures are actually from a couple of years ago. Now he's sneaked down his entire pupil. You can see all this pigment, miraculously is seeing 20/25. This was his prior episode where they broke the posterior synechiae. This eye is now also sneaked down 360. And I'm just trying to avoid flares and avoid cataract surgery in this young patient as much as possible. So mainstays of treatment, topical steroids, prednisolone or difluprednate. My general principle for anterior uveitis is if you see 1+ cell, and we won't go into the grading pattern, prednisolone 4 times a day or more. 2+ is 8 times a day. You just keep going. That's the ratio. Frankly, HLA-B27 patients, they are often hourly prednisolone or hourly difluprednate. And then a long, slow taper for these patients, about 2 months. We'll start hourly for a few days, a week, every 2 hours for another week before you really start coming down. They have a tendency to flare if you come down too fast. Cycloplegia is for the prevention of posterior synechiae. You actually do want a little bit of movement. So atropine is not a good medication here because they can scar down their pupil dilated. And then you get the same problems of pupillary block. You just can see it. So you actually want a short-acting agent where the pupil is moving a little bit. And then you want to maintain this until you get just trace inflammation. And then oral steroids. Amde talked earlier about, indications for oral steroids. This is a great place to use them for patients who have hypopyon or fibrin. I like it because it's aggressive. It acts fast. You can titrate it. You can extend the steroid. You can decrease it quickly if they're doing better. And then we think about immunosuppression for these patients if they're having more than 3 flares a year. So really they're on topical steroids more than they're off. If they've gotten into this chronic nature where you just can't, they still have persistent inflammation, or if they have any associated systemic disease that warrants immunosuppression. So this is another patient with HLA-B27 anterior uveitis. She's now sort of chronic anterior uveitis. This was, I think, like 5 years ago. She can see she actually she had cataract surgery. She developed posterior synechiae to her lens, and she has some Elschnig pearls. Those got worse. She underwent surgery. They released the synechiae, but you can see she already started to reform again. And then the scarring just kept getting worse, and she came to me complaining of significant peripheral vision loss. And so after a long time of waiting it out, we finally did surgery for her. And so we released, she had synechiae going all the way around. Like you couldn't even see this. It was like from the pupil margin all the way back. And you can see her IOL is a little bit superiorly subluxed. I had to cut this entire sort of anterior capsular rhexis, all this phimosis. And then we're actually going to come back and do a YAG capsulotomy for the back just to open up her visual axis. So that's really what you don't want to have to do for these patients. So if you start topical steroids early, frequently, keep it on for a while, oral steroids if necessary will be great. And then principle number 4 is to ask these patients, HLA-B27 positive patients specifically, but also just any acute anterior uveitis patients, about systemic symptoms. And the associations with HLA-B27, which Dr. Kleiner will go into, are your seronegative spondyloarthropathies. Seronegative meaning rheumatoid factor negative. So things like ankylosing spondylitis, reactive arthritis, psoriatic arthritis. HLA-B27 is also associated with inflammatory bowel disease, so Crohn's, ulcerative colitis. And the data show that at least 50% of your HLA-B27 patients will have some systemic disease majority of them having the spondyloarthropathy. So it doesn't take too long to ask them, do they have any joint pain, low back pain, tendinitis, and then any diarrhea, bloody stools, GI symptoms, and then you can make the appropriate referrals. Dr. Kleiner will go into a little more detail about how to evaluate this. So in summary, approach to anterior uveitis, make sure it's anterior, make sure you rule out infection. Everybody that walks into my clinic, and I think Amde's clinic, gets a syphilis and a TB test, no matter how old you are or what, universal. HLA-B27 is the most common etiology. Treat it aggressively with steroids, and then ask them about systemic symptoms.
Our next speaker is going to be Dr. Anatol Kleiner. Dr. Kleiner is an assistant professor of medicine in the division of allergy, immunology, and rheumatology. Given the frequent need that our uveitis specialists have to work with rheumatology on these complex patients, it's great to have him here, and he's a frequent collaborator with our department. Anatol practices adult rheumatology and is also an adult and pediatric allergist immunologist. His clinical interests include autoimmune and inflammatory disorders, including lupus, Sjogren's, rheumatoid arthritis, psoriatic arthritis, and ankylosing spondylitis. He did his undergrad at Harvard and then his medical training at SUNY Stony Brook, completed his residency and fellowship here at the University of Rochester, and his presentation is going to be on seronegative spondyloarthropathies.
Hi, everyone. Good morning, or almost afternoon. Thanks for having me. When I did my fellowship training here at the university, that was when Dr. Chris Richland was still the program director, and some of you may know that he's an internationally recognized expert in seronegative spondyloarthropathy and psoriatic arthritis. So as I was training, I was seeing many of these patients, and the more patients you see with seronegative spondyloarthropathy, the more you realize, oh, a lot of these folks get anterior uveitis, and then we have this group of patients that travels back and forth between my office and your office, and then you realize you're providing asynchronous care, right? You're making diagnostic decisions and management decisions one week, and then your counterpart sees the patient several weeks later, decides something different, then they come back to you. So over time, I really started to think, well, can we do better for our patients? Can we deliver multi-specialty care in a single setting at a single visit, and hopefully make things more convenient for the patients and provide better care? And that's what Wen and I have been working on with our joint clinic. So I'm going to talk to you today about seronegative spondyloarthropathy. I have no disclosures. So the knowledge goals, we're going to talk about what are the most common seronegative spondyloarthropathies. When should you really start to think about your patient having one of these problems if you're seeing someone who presents with anterior uveitis, and what diagnostic workup might be helpful to evaluate? What can you do on your own? When might you want to think about referring to a rheumatologist? Definitions. These things, the seronegative spondyloarthropathies, these really encompass a group of conditions. So ankylosing spondylitis is sort of our prototypical seronegative spondyloarthropathy. You'll sometimes hear it referred to as an axial spondyloarthropathy. Psoriatic arthritis, of course, we see IBD-associated arthritis, reactive arthritis, which we used to call Reiter syndrome. And then there's also a term of undifferentiated spondyloarthropathy. And these conditions are all grouped together because they have a number of things in common. They're all classically associated with the HLA-B27 genotype. And these are also the only forms of inflammatory arthritis that we see that affect the axial skeleton. You know, they are distinguished from things like RA or inflammatory arthritis with lupus, is in that none of those conditions affect your spine. Spondyloarthropathies, the seronegative spondyloarthropathies, are the only ones that do this. They're also characterized, it's an important concept. You can't have a lecture about spondyloarthropathy without talking about the enthesis or enthesitis. So we'll get into that as well. So in terms of epidemiology, ankylosing spondylitis is the most common spondyloarthropathy that you'll see. And this is, depending on what study you look at, up to 1.4% of the global population. So, a room of 100 people, you probably have one person there that has it. More common generally in men than in women. And almost all of these patients, 95% of them are HLA-B27 positive. Psoriatic arthritis is probably our second most common seronegative spondyloarthropathy, and the prevalence data for this are variable. Probably the highest numbers are about 0.25% in the US. And I think an important point to realize is that psoriasis in the skin is exceedingly common. That affects about 3% of the US population. But most patients with psoriasis do not also get psoriatic arthritis. So in our clinic, what we see much more commonly is patients who have psoriasis of the skin and also have osteoarthritis, two unrelated problems. But of those that do get skin psoriasis, about 6, maybe up to 41% will go on to develop psoriatic arthritis, which we think of as an inflammatory arthritis that's associated with psoriasis. And the reason for the wide range in prevalence data there, it depends in part on what case definition was being used at the time these different studies were published. So realistically, 41% is a little high. Chances are the real number is around 10 to 20%. And HLA-B27 is also seen in association with psoriatic arthritis, but much less commonly. Only about 20 to 35% of our patients with psoriatic arthritis are HLA-B27 positive. And in general, the background prevalence of HLA-B27, again, it depends on what racial and ethnic group you're looking at. In the US, it's somewhere between 7 to 8% for all comers. So that's why we don't routinely test for this with everyone who has back pain, because a lot of people will test positive, and it may not really be helpful in an unselected population testing for the gene. So I think the question that is more relevant or interesting to you guys is, well, let's take our population of patients who have anterior uveitis. How many of those folks are actually going to go on and develop a seronegative spondyloarthropathy, or how many of those already have a spondyloarthropathy? And we don't have great data about this, but we do have some. So this is a recent study that was published just last year, looking at a cohort of 102 patients who came in consecutively with recurrent acute anterior uveitis. And they matched these folks with 42 healthy controls, and 75% of that population was HLA-B27 positive, compared to about 5% of controls. Again, 5% is what you might expect for the background population. And every one of these patients with anterior uveitis had an X-ray of their SI joints, and they had an MRI of their SI joints. So what you see is that 20% of those patients had sacroiliitis on an X-ray, and these were patients without any prior history of spondyloarthropathy. And 34% of them had sacroiliitis by MRI. So there's a lot of these patients out there in your uveitis population, many of them undiagnosed, and the simple screening can help identify them. Initially, 40% of this particular cohort was diagnosed with axial spondyloarthropathy. It's a larger study. This is about 7 or 8 years old. This was published in Ophthalmology. So this is looking at a total of almost 800 patients, and who presented with recurrent acute anterior uveitis, and they stratified them based on HLA-B27 status. So in this group, 475, so that's almost 60% of the group was HLA-B27 positive. And what you see is that this gene helps you predict what kind of features you're going to see in your population of uveitis patients. So there's a number of things that were enriched in the HLA-B27 positive group, but specifically, I want to show you or focus on inflammatory back pain. So half of the patients that were HLA-B27 positive had inflammatory back pain, compared to only a quarter of the HLA-B27 negative group. Again, there's the findings of sacroiliitis, both on X-ray and MRI, so much more commonly seen in the HLA-B27 positive group. And then, 71% in this cohort of patients were ultimately diagnosed with axial spondyloarthropathy. So this is quite common in our uveitis patients. So again, you can't have a lecture about spondyloarthropathy without talking about the enthesis. And the enthesis is essentially an anatomic site where ligaments or tendons attach to the bone. So we have these throughout our body. On the left there, you can see a magnified version of the spine. And those little spots in purple are places where we have entheses. So where the annulus fibrosus of your intervertebral discs attached to your vertebral body, where your anterior and posterior longitudinal ligaments attach to your vertebral bodies, where your intraspinous ligament attaches to your vertebral spinous processes. So entheses throughout the spine. In the middle, you can see a common one, the Achilles tendon enthesis. So a common spot of inflammation or enthesitis in our patients. And you also have plenty of entheses around synovial joints. That's on the right there. So a typical synovial joint, say that could be an interphalangeal joint, and you can see where the tendon attaches to the bone there. So the enthesis is really a crucial organ or anatomic site in spondyloarthropathy. And it's felt that this is where inflammation initially arises in spondyloarthropathies, in part potentially due to mechanical trauma and inflammatory cascade at the enthesis site. This is characterized by inflammation, swelling of the enthesis, and eventually bony proliferation. And in the spine, you get fusion. In other places, you get what we call enthesophytes, so bone spurs, essentially. So this is another study that was using ultrasound of the entheses to characterize our patients with recurrent anterior uveitis. They basically looked at 4 groups of patients, or 5 groups rather. The first group were patients with, on the left there, were patients with known spondyloarthropathy. Groups 2 and 3 were patients with recurrent anterior uveitis. The second group, HLA-B27 positive, the third group, negative. And then groups 4 and 5 were control groups. Group 4 was uveitis not related to spondyloarthropathy. Most of those patients had infectious uveitis. And then group 5 was healthy controls. And they were looking at this thing called a MASI score. And I don't think you need to know the details of this other than to know that it's a score used by ultrasonographers to grade severity and extent of enthesitis. A higher number implies a greater degree of enthesitis. So if you look at the mean values of the MASI score across these groups, as you might expect, the group with spondyloarthropathy has the highest mean MASI score, followed by the group that is HLA-B27 positive with anterior uveitis. And actually, those 2 groups were not statistically significantly different from each other. So in other words, the degree of enthesitis that was seen in patients with known spondyloarthropathy was the same as that seen in patients who are HLA-B27 with positive with recurrent anterior uveitis. So this is what enthesitis might look like clinically. You look at the patient's left heel and you compare with the right, and you can see that the insertion of the Achilles tendon is quite swollen. It's typically quite painful. These patients have morning stiffness. They have trouble rising onto their toes. That causes pain. This is what enthesitis might look like on an X-ray. So this is a lateral view of the patient's ankle. And you can see on the bottom there's a large enthesophyte and then a secondary smaller calcification at the insertion of the plantar fascia. So again, a common enthesis where the plantar fascia inserts onto the calcaneus. And then if you look at the back of their heel, you also see this quite massive enthesophyte at the insertion of the Achilles tendon. So an X-ray sometimes can give you a clue if it's clinically not apparent. This is what enthesitis might look like on an ultrasound. So window A is a normal ultrasound, a longitudinal view of the calcaneus and Achilles tendon insertion. So the calcaneus there I outlined for you, and just take the red away for a second. You can see sort of the linear fascicles there of the Achilles tendon. We call that anisotropy in ultrasound. So again, you can see the Achilles tendon inserting onto the calcaneus, a longitudinal view. If you look at slide B, that's also a longitudinal view of the Achilles tendon insertion, But there you can see that the fascicles are sort of spread out from each other. There's all this anechoic material there. That's edema in the Achilles tendon. And then you can see that little red blotch. This was a scan with a power Doppler signal assigned. So that's an erosion in the bone of the calcaneus. And the red tells us there's increased vascularity and blood flow. That's a sign of inflammation on our musculoskeletal ultrasound. So that's what you might see if you were ultrasounding the Achilles enthesis. In slide C, you can see an enthesophyte on the ultrasound. Different patient. The yellow arrows, you can see that bony protuberance there, which is, again, it's growing from the site, the bottommost site of the Achilles tendon insertion. So this is what we typically use when we think about axial spondyloarthropathy. This is a classification criteria. ASAS is it's an acronym for Assessment of Spondyloarthritis International Society. So it is a classification criteria, not a diagnostic criteria, differences between the two, but I think it's a very helpful framework to think about patients who have seronegative spondyloarthropathy. So the most important part of this criteria is at the top. We only think about this in patients who have chronic back pain, so greater than 3 months of back pain, who are typically young, less than 45 years old. And then the second part is that these patients, if they have chronic back pain, they either have sacroiliitis on imaging and one additional feature that we think of with spondyloarthropathy, or if you don't have imaging available, they are HLA-B27 positive, plus have 2 other features of spondyloarthropathy. And you guys, I think for you, you're kind of working at this in reverse, right? These patients are showing up with uveitis. So you already have one feature that's potentially associated with spondyloarthropathy. And it's very simple to ask, again, ask about back pain, ask about any joint manifestations. And then these additional features, enthesitis, dactylitis, psoriasis, inflammatory bowel disease, family history, these can all help steer you in one direction or another. Now, since you're asking these patients about back pain, you also want to really try to characterize it and think about what we call inflammatory back pain. So why characterize it? What do we think of as being inflammatory back pain? The issue is low back pain is, that's the most common musculoskeletal problem we see globally. It's the leading cause of activity limitation, absenteeism from work. As of 2017, it was estimated to affect 7.5% of the global population, which is 577 million people. That's almost twice the population of the US. So if you're asking your patients about, do you have back pain? I guarantee almost all of them will answer in the affirmative, especially if as they get older. So if you look at the point prevalence of lower back pain, it peaks at the age of 80 to 84. So over 20% of patients at that age have lower back pain. Now, the overall global prevalence is 7.5%. And you see, if you look at younger ages, as you might expect, back pain is a lot less prevalent. So that's why those criteria that we use, they emphasize, this is a patient that is less than 45 years old with chronic lower back pain. So inflammatory back pain, these are the features that we typically associate with having inflammatory back pain. It's not pain that began after I fell off a ladder, or I was in a car accident, or I was moving my parents' couch. Patients will not be able to tell you when this started. They'll say, yeah, years, I've had it for a long time. Generally gets better with exercise. It gets worse with rest. These patients will have night pain, especially in the second half of the night, and they're very stiff in the morning, often an hour, 30 minutes is our cutoff. And they also have alternating buttock pain that's at the sites of their SI joints. So patients who have inflammatory chronic lower back pain, that helps you select for these patients that will have potentially an axial spondyloarthropathy. So what I often do when I'm working up these patients, in terms of blood work, I think an HLA-B27 gene is very helpful. We look at acute phase reactants. As the name implies, these are seronegative spondyloarthropathies, so they are typically negative for rheumatoid factor, negative for CCP antibody, negative for ANA. And then imaging is extremely important. So think about x-raying your symptomatic joints, if they have, an ankle that's bothering them, or at the very least, an x-ray of the AP pelvis or the SI joints to look at possible sacroiliitis. And then if your x-ray is normal, you might also want to think about an MRI of the SI joints. So here's an x-ray of a 32-year-old male, an AP pelvis, who has very likely had long-standing ankylosing spondylitis. So I put some arrows to where the SI joints typically would be. You'll notice they're completely fused. And then I also drew an arrow. You can see what would be fine ossification of the annulus fibrosus of the intervertebral disc. And you can follow that all the way up the spine here. So this patient, at least what we can see of this patient's spine, is completely fused. If you look down the middle of the spine, that's ossification of their interspinous ligament. So this is what a case of long-standing ankylosing spondylitis might look like. This 48-year-old male, here you can see the SI joints are mostly patent, but if you look, this person has an erosion on the iliac side of their SI joint, and they have some increased bony sclerosis. So these are signs that you might see on an X-ray of someone who is earlier on in the course of their spondyloarthropathy. But the big problem with X-rays is that by the time patients develop radiographic findings on plain films, they have likely had spondyloarthropathy for 5 to 10 years. So this is a condition that is extremely slow going. So if you are relying on X-rays for imaging of sacroiliitis, you are going to miss a lot of patients. You'll make them wait, 5 to 10 years before they get diagnosed, and you don't want them to end up like this if you can prevent it. So why might one do an MRI? The sensitivity is much better. This is a comparison of the same patient. So on the left, you can see the X-ray of their AP pelvis, and this looks essentially normal. Those black arrows are pointing to an area where the patient might have a little bony sclerosis, but it's a soft call. But if you look at the MRI, the same cut on the MRI of this patient, the arrowheads there are pointing to erosive changes that are seen already in the patient's left SI joint. That long, thick arrow is pointing to, this is a T1 weighted image, it's pointing to an area of fatty replacement of the bone marrow. So another change that's associated with chronic inflammation. The thin arrow is pointing to an area of sclerosis. So the advantage of MRIs is that not only do they give you better spatial resolution, help you identify erosions, but they are also good at imaging inflammatory lesions. So an X-ray will not show you, is there inflammation, is there not? It'll just show you consequences of past inflammation, whereas an MRI might show you bone marrow edema, things that we think of in terms of active inflammation. So to summarize, I hope I've convinced you that seronegative spondyloarthropathies are pretty common, especially ankylosing spondylitis, and significantly more common in our patients who present with recurrent non-infectious anterior uveitis. Chronic low back pain, especially inflammatory low back pain, is something that should really be a red flag to make you think of an axial spondyloarthropathy. And then also think about enthesitis and sacroiliitis as defining features of our spondyloarthropathies. And again, our current practice really emphasizes imaging of the SI joints. So I think if you have a patient who has recurrent acute anterior uveitis, really think about at least a plain film of their SI joints, and then think about whether that patient also might benefit from an MRI of their SI joints to help identify them. All right, that's all I got, folks. Thank you.
The closing speaker for our session will be Dr. Alex Levin. Alex is the Chief of Pediatric Ophthalmology at FEI and the Lutz Ching Professor of Ophthalmology. He's also the Chief of Clinical Genetics for Golisano Children's Hospital and the University of Rochester Medical Center. As you know, Alex joined us almost 3 years ago. No, 2.5. After spending 12 years at Wills as the chief of pediatrics and ocular genetics. Prior to that, he was on faculty at Toronto's Hospital for Sick Kids, where he established and directed its ocular genetics program. He has a wide variety of clinical and research interests and has over 300 publications. And since arriving here at FEI, he's really directed an impressive expansion of our pediatric ophthalmology service. This has included, among other things, establishing our ocular genetics program, the addition of clinical and research fellowships in ocular genetics and pediatric ophthalmology, and starting New York State's first gene therapy treatment center. Most recently, he has spearheaded a training program for genetic counselors, and this fall we will welcome our first class. Alex today will be presenting on pediatric uveitis.
Thanks very much. Those are two great talks on adult uveitis, but kids are not little adults, right? Totally different world. Like, we don't get to use the term anticipate very often. We're more often use terms like booger and fart. That's the language we speak. And our world of uveitis is also very, very different. So bunch of publications we did over the years on this, and my talk will be drawn from that, but also from an international consensus conference on GI-associated uveitis that we held. We had 3 meetings, and this was, we brought 22 experts in pediatric uveitis from around the world who got together and sat around a table, 3 different sessions, and kind of thought about what are the right ways to do this. And some of that will be reflected herein. So 10 tips. Number 1, try to make a diagnosis. Unlike adult uveitis, where it's said that 70% of the time you don't get a diagnosis, in kids, 70% of the time we can get a significant clinical diagnosis that can direct your treatment. The most common cause of pediatric uveitis is by far and away trauma, but in the absence of that, it's JIA. Then you get down to the idiopathic, which is about 30%, and then a list of other things, including HLA-B positive, which was mentioned here. The infectious uveitis, and Wen did a great job of stressing how important it is to consider these. Chickenpox, though, is a very benign uveitis, doesn't often need any treatment at all. But we see some of the others that are seen in adults, but less than we see in others. Fortunately, we see less syphilis, for example. But it's always something to consider. And COVID is one that should always be considered. That has shown us that it can cause uveitis in kids. A COVID vaccine can aggravate kids who have existing JIA uveitis, for example. So that's always in your differential. So there's many common causes. It's important to remember that 10% of juvenile idiopathic arthritis will present with the eye first without any joint symptoms. Although sometimes a good referral to pediatric rheumatologist will discover things that we might miss on exam and history. That's generally true. And I think when thinking about all these possible diagnoses, remember that when you got your ophthalmology certification, you didn't give up your license to examine the rest of the child. Like, don't have this sign on your doorway. I got a stethoscope, use it, listen, feel, look, and you can find things that can be very important in making a diagnosis. Do your review of systems. Look for all these things that are listed here that can point you, mucosal alterations for Behçet disease, for example, diarrhea, weight loss. All of these things can help lead you, as well as the typical travel, pets, and family history. And we do a physical examination, looking at the rest of the body. That can be very helpful in making a diagnosis, especially in peds where we can make a diagnosis so often. Here's an example of a kid who came in with a bulbar conjunctivitis and a bit of uveitis, and asked a few questions, and that led me. I don't recommend this on every child, but I examined his buttocks, and sure enough, he had this papulosquamous rash, and he had fever and had lymph nodes and adenopathy and some peeling on his fingertips, and he has Kawasaki's disease, mucocutaneous lymph node fever. So a good examination, if you look far enough, will sometimes get you where you need to go. For the workup, my first line of labs is listed here with a little bit of, sculpting as you go along, but your CBC and differential is critical because of leukemia in kids, which can present in the eye, and is a very important negative prognostic sign. And if you treat leukemia with steroids, it goes away in 2 seconds in the eye and you miss the diagnosis. The ANA is so big, I'll talk about that more in a second. That's in particular for JIA, of course, the SED rate. We use the ACE and the calcium, not the greatest test to screen for sarcoidosis, but sarcoid in kids looks very different than sarcoids in adults and can be harder to make that diagnosis. Sometimes it presents just as a skin rash. The urinalysis, electrolytes, BUN, and creatinine are for involvement of the kidney that we see with sarcoid, but also for TINU, tubular interstitial nephritis and uveitis, which is mostly in young teenagers, beta macroglobin as well. Chest X-ray, looking for sarcoid TB. And we do a VDRL, we do test for syphilis. And actually it's less because we think it's likely, but more because of the public health concern and the concerns about abuse and neglect. So we do that on all of our kids. And a TB test in this time of rising TB is always a wise thing to do. And most importantly, rheumatology consult. That's kind of the part of our initial workup should be a rheum consult, because so often that's going to be where the answer lies in children. Second line labs, again, are very sculpted to what are the most likely things. There's a whole number of tests you can do. HLA-B27, I wouldn't have order as a first line test in a kid unless they had a painful symptomatic uveitis. But these are as needed. But tip number 2 is know the JIA risk factors. So if you have a kid who's got JIA, you know, what type of JIA do they have? How many joints are involved? What's their ANA and rheumatoid factor status? What's the duration of their systemic and eye disease? How old are they and their gender? Because these are things that are going to predict to you the kids who are more likely to get uveitis. Higher risk, young girl, oligo extended, 6 or less joints, ANA positive rheumatoid factor. That's your high risk red flag group. And older boys with sacroiliitis or polyarticular disease or ANA negative rheumatoid factor positive. These are your high risk categories, and that should help you screen appropriately. And screening is really critical. I can't tell you how many kids I have seen who get to me, by the time they get to me, they got cataract, they got glaucoma, and they never had a symptom. And that's where we don't want to be. We want to pick this disease up early. Kids have to be screened routinely. This is from 1987, and it's probably the most telling slide I've ever shown. If you look at kids who on their first exam have no synechii, here's the outcome. This is for JIA. Now, 28% cataract, still not very good, right? But if they have synechii, look what the numbers do. You got to screen. You want to get to them before they get to this point, and you can make a huge difference, especially in today's world, as I'll talk about with the drugs that we have available. The cost benefit, it's, you know, the cost of an exam is really cheap. The inconvenience is really nothing. And there's a clear benefit to early diagnosis and treatment. Remember that severity is not associated between the eye and the joints. You can have bad joint, you can be wheelchair bound and have a quiet eye. You can have terrible eye disease and have no joint symptoms. You can't use that as your marker. You have to keep screening regardless of the activity of the joint disease. This is from a recent paper from CHOP. I think it's very important. 49% of patients had symptoms at their first uveitis, of 34% if you're JIA. So less have symptoms with JIA. 69% have symptoms if you're non-JIA. So it's an asymptomatic disease in JIA, the most common cause of pediatric uveitis, right? If you're symptomatic at your first uveitis, 35% are asymptomatic at their recurrence. So you can't go by eye signs. You're going to miss it every time. And in non-JIA, if you have non-JIA, older age, or ANA negative, you're more often going to be symptomatic. So symptoms in kids are not a good sign to base your screening on. How long do we screen for? We're not really good. The risk is 0. We don't know. There's one case of a woman who got uveitis 35 years after the diagnosis of her JIA. We don't know. And I tend to be on the side of just keep screening. The cost benefit has yet to be calculated. And along with that is tip number 4, know what to expect, right? 25% of kids with JIA arthritis are going to have a mild course, quick response to steroids, and will never come back again. 25% are going to have a severe, poor prognosis. That's 90% of my practice. Surgeries often needed, worse visual outcomes. These are the kids that are chronic patients and go on and on and on. And then there's 50% of kids have a moderate course where they have recurrent. They get it, you treat it, goes away, they're fine. They get it, you treat it, goes away, they're fine. It's the last category that's really awful. So you have to treat aggressively, and don't be afraid of steroids. You know, you can't kill an elephant with a pistol, and this disease can be an elephant, and you have to be aggressive. And it's so true that the disease is worse than the risk of steroids. The risk of cataract, glaucoma from untreated uveitis is far, far worse than the risks from steroids. We published a paper a long time ago, and I'm a very heavy-handed user of steroids. And our paper showed a better rate of glaucoma and cataracts, not a higher rate, because we were really aggressive in treating the steroids. That was before we had anti-TNFs as well. NSAIDs don't help in kids. It's been well shown since Olson's paper in 1988. They really have little or no effect. And remember, in kids, putting drops in is difficult. Shake that bottle really well. Leonard App, the first double-boarded pediatrician, pediatric ophthalmologist, wrote a paper that it takes 50 shakes of a bottle to accurately disperse the suspension. Tell parents it's white. It's supposed to be white. It's going to run down the cheek so they don't get afraid and stop using it. I usually start at 4 or 6 times a day for that first episode and try and wean quickly. But if I need it and that kid's really inflamed, I'll go to every hour to start off to try and get them under control. Remember, the risk of that being untreated is worse than the risk of a short course or even a longer course of frequent steroids. Remember that kids sleep a lot. They sleep 12 hours a night. That's 12 hours of untreated time. You want to give them something that lasts during that time. We don't have a lot of good options in our pharmacy these days. Lotamax gel is about the best. There's no steroid-only ointment. Ointments are great. We had dexamethasone in Canada, although it's very glaucomogenic. And also remember that FML does work. In kids, it does get in the eye. You can treat uveitis, not as a first-line drug, but Dorzol and Bexol seem not to work as well in kids for some reason. We use prednisolone. Oral steroids are really only used in specific circumstances. It's a topical treatment for disease. We recommend 1 to 2 milligrams per kilogram as a test. If you really have a kid you don't know if steroid is working or not, give them a shot of steroids, give them a 3-day course for that kind of quick fix in a really inflamed eye. Certainly, if the whole eye is inflamed, you're going to need a more systemic treatment that works quickly. Rule out TB, rule out infection. And we use it for pre and post-operative management. 3 days pre-op, we start steroids, and then we continue it for somewhere around 7 to 10 days post-steroids, because you can stop it in kids cold turkey up to 14 days. And we dose it once in the morning. Subtenon steroids are also good, not as a routine, not in our routine treatment ladder, but they're good in kids who are steroid responsive, but they need a bridge, particularly when you're starting another systemic drug. You've got a waiting period for that drug to work. I've done it as young as 7 weeks awake 7 years old, awake in the office. It'll last from 4 to 12 weeks. It's a very good alternative to high-dose topical, or it can be additive as well. It's kind of this bridging, helping therapy. I avoid it in kids who have glaucoma, of course. And whether you go superior or inferior is just a matter of preference. Tip 5A, steroids are great, but they get you a lot of trouble. Wean slowly. The most common cause of failure in pediatrics is weaning steroids too fast. We see it all the time. People put them on 4 times, 6 times, and 5 times, 4 times, and within 3 weeks, they're off of steroids and they got a raging uveitis. You have to go slow, especially in that 25% with the chronic disease category. The other is noncompliance, right? Especially teenagers, immune to all diseases. They don't take their medicines. And you want to ask these questions. First episode, try a quick wean. If that fails, then you can go with a slower wean, back off, go slower, maybe in 1 drop less every 4 to 6 weeks. Recurrent cases may or may not allow quick weans, different for every kid. And think about percent when you're weaning. Going from QID to TID is a 25% wean. TID to BID is a 33% wean. Those are big jumps. And every time you wean, see the kid a couple of weeks later to make sure it's not coming back. Some kids only need a tiny bit. I have a patient who needed 1 drop a week. I couldn't get him off it. I have no idea why. But again, the most common cause of failure in a teenager is noncompliance. So ask, what times are the meds given? You write it for 4 times a day. So the parents give a drop at 7:30 before school, 8 o'clock before school, 4 o'clock after school, and 5:30. That's not 4 times a day, right? Are they getting their drops in school? You might have to write a letter to get the drops in school. Schools have to give drops, regardless of what the frequency is. You can't say, sorry, you can't come to school because you're on a medication. They have to do it, but it may require us writing a letter to do it. And ask who gives the drops. Oh, my 12-year-old kid, he gives it to him. Like, he's not getting the drops. And we say, the kid comes in, same with glaucoma. They're out of control. I say, okay, let's treat the child like a child. For the next 2 weeks, I tell a parent, you give every drop and then come in and let me see. Then they come in and they're fine. You know what the problem is. Prevent synechia, use a dilator. I was so happy to see Wen talk about that. It's really important. Kids are in general pro-inflammatory and pro-synechia, if there's such a word. You want to keep that pupil moving to increase that surface area while trying to preserve accommodation, especially in the young kids who are amblyogenic. I also like cyclopentolate, sometimes just once at night. In those active chronic kids, I have them on atropine. I'll give them their cycloplegic refraction if they need it, or readers to help them in school. And keep those drops going even when the kid's controlled. Because when that kid stops taking his meds and gets inflammation asymptomatically at home, the drops are working while you're not, right? They're at least preventing those synechia until you see that kid again and find out they're in a recurrence. Tip number 7, this has been the big change in our world, is don't be afraid to go to systemic treatment early and long term. And this is one paper. There's many papers out there from various consortia saying the same thing. We all use the same pattern in pediatrics pretty much. We often get a rheumatologist to help us or a pediatrician to help. But if the steroids are failing, the dose is too high, then we go to methotrexate first. We usually start orally. If the kid can't tolerate it, usually it's for GI side effects, then we move to subcutaneously. Takes 4 to 6 weeks for that effect. So you have to be willing to tolerate some little bit out of control or use of steroids, or maybe do a subtenons in the interim to get you by. If that fails, we go to the anti-TNF drugs. Infliximab and adalimumab are 2 main choices. One's an injection, Humira, Remicade an infusion. We showed a long time ago, the first paper, that Enbrel is not a good drug for pediatric uveitis. This has been a huge advance for us. The effect is quicker, 2 to 3 weeks, very reasonable risk profile, but they are not a cure, right? They can be. Some kids will still need some steroids on them, and it is very, very costly drug. And children who get colds all the time, right? If they get sick, they often have to stop their anti-TNFs, and then you should see them again 2 weeks later to make sure they didn't relapse in the meantime. And then there's other biologics, golimumab and mycophenolate and so on and so forth. We use them. What we rarely use these days are the hardcore immunosuppressives, Humira, cyclosporin. There's specific diseases where they're helpful. They have higher short and long-term risks, and that's why the anti-TNF. So topical drops, methotrexate, anti-TNF is our ladder, with some deviations in between. Tip number 8, stay out of the eye. We all like to do surgery. In these cases, you want to not do surgery. We got a lot of good drugs in pediatrics, and use them. You can use an alpha agonist over a year of age. We just published a paper, latanoprost does not cause uveitis in kids like it can in adults. Use acetazolamide. I would much rather a kid be on acetazolamide than operate if I don't have to. You want to avoid surgery. And this is kind of new. It's happened the last several years. Goniotomy is now, or some people would call it goniosynechiolisis, but really goniotomy is the first line treatment. It's got a 75 to 80% success rate in uveitic glaucoma. We rarely use trabeculectomy in children for a variety of reasons. And when we use tubes, when gonio surgery fails, we prefer a tube without a valve, something like a Maltino or a bar valve. Uveitic cataracts, you know, who knows? Is it the iritis? Is it the steroids that causes it? It often starts as a PSC. It can come on very quickly, very densely, can be intumescent cataract, but still avoid surgery. Like, why would you do surgery? Well, if your vision is down in both eyes, if it's intolerable vision loss in one eye, if I've got a 12-year-old kid who's got a cataract in one eye, quiet uveitis, well-controlled glaucoma, he's fine. Not going to get amblyopia. Cataract's not bothering him. It ain't bothering me. I'm going to let it in until I know he's well past his uveitic years. If it's intumescent or phacolytic, of course, you have to do it. If you need to see in the eye because the kid has glaucoma, you have to. But we don't do it just because it's a white pupil. And we avoid IOLs in kids with uveitis. This is a kid who came to see me from Australia. He came in with 2200 vision, pressure out of control, iritis, and I took out his IOL. His uveitis was controlled, his vision went to 20/30. I mean, IOLs in kids, it's just like putting a time bomb in the eye if they've got uveitis. When it works, you can pat yourself on the back. You did a great job. When it doesn't work, you'll be crying all the way home. It's really something we try and avoid. Closing up, be available and give intense follow-up. This is a tough disease in kids. You really have to be with them all the time, essentially. And that leads me to number 10, which is if you can't stand the heat, get out of the kitchen. Uveitis is not, pediatric uveitis is not for everybody. If it's not something you're willing to do regularly, put the time in, you shouldn't be doing it. And send it to someone like Dr. Haney or someone out there who really likes to do it, and you'll get where you need to go a lot faster. So it's intense and challenging, constant care and follow-up, often get a diagnosis. It's a chronic disease, which is good. You get to know the families, and it's a lot of fun. That's all I got. Thanks.
Great. Thanks, Alex. We have about 15 minutes for discussion. I'd like to open it up first. Are there any questions for the panel?
I have a question for Dr. Kleiner. So, first of all, I would like to thank you, for working with Dr. Hu. I'm jealous of that collaboration. So when we see a new patient with a unilateral anterior uveitis, about half of them are HLA-B27 positive. The others are negative. So possible causes for the other 50%, maybe 5% could be viral. Maybe 1% could be sarcoidosis. The other are idiopathic. So we get lost at that point. So based on your slides, about 90% of AS patients are HLA-B27 positive. The other 10% are negative. So is it possible, these patients could have, low back pain, which could be, HLA-B27 negative disease, and could that be the cause of the uveitis, for example? Just to give another example, patients with IBD, most of them are HLA-B27 negative, but they still could have uveitis. Could there be like a low back pain like disease, which is HLA-B27 negative, but could be the cause of uveitis? I mean, could those patients could have IBD, for example?
Yeah, I think that's a great question. And, if you think back to those criteria that I showed you, our classification criteria for spondyloarthropathy, HLA-B27 is not essential. So all you really need to have is a patient who has chronic lower back pain and then some additional features of spondyloarthropathy. So that could be inflammatory back pain, sacroiliitis on imaging, or say psoriasis. So most of our other forms of seronegative spondyloarthropathies are much less commonly associated with HLA-B27. So psoriatic arthritis, again, is very well known for causing axial arthritis, inflammatory arthritis of the spine, but most of those patients are HLA-B27 negative. But, psoriasis is usually pretty easily evident on skin exam, or they have a family history of psoriasis. And as far as ankylosing spondylitis patients, it's becoming increasingly well recognized that, especially in female patients who develop AS, they're more likely to be HLA-B27 negative. And there's actually, we used to think that AS was almost exclusively a male disease. And as we learn more about it, especially over the last decade, it's becoming clear that, it's not quite 1-to-1 male-female, but much more common in females than we originally thought. And many of them will be HLA-B27 negative. Hope that answers the question.
I've got a question for Alex. Hi, Alex. Thinking back 20 years ago with our kids with JIA, before Remicade, before most patients would put on methotrexate for their joints, do you feel the kids that have joint disease that are on a biologic have less spontaneous iritis coming into our office? Does that make sense? So patients are on medicines for their joint disease. We're still screening them every 3 months, but I'm not seeing as many kids that are breaking through with iritis on those. And should we take that into account when we're screening?
I think that's the effective screening. I agree. We see many kids who are on these medications before they ever got uveitis, right? So we're seeing less patients who get it, probably because it's being warded off by the drug. There's no question there's advantages to long-term treatment with these drugs, but many of the kids come to us first, right? And they wind up on their anti-TNF from us. But even those, once they're on their anti-TNF, you're seeing less recurrences, which is the goal of the disease.
I definitely seen less of that roller coaster than I did.
Question for Vikas. Are we doing genetic testing on all of our ocular melanoma samples, or will we be? And what's the utility of genetic testing at this point?
We have not been doing, and Celeste is actually working very hard. We're trying to set up that. So enucleated specimens, it's easier to do because we have a lot of sample. But with plaque, there are companies available, so you just need very little sample. It's a method. We need to know what vials we need to put that sample in. We don't know the exact time frame, but it'll just classify the patient as either class 1, A, B, or 2. And we can just tell them that you're at higher risk of developing a metastatic disease and screen them. So nothing from treatment perspective, and no timeline as well. So that's why there are centers that don't offer it at all. They're like, it's adding no benefit. No idea. I mean, we're getting closer to, but time frame, I think, will be very hard to say. Again, it's at what time. So if it's an older patient, so if you look at all-cause mortality in melanoma, that's much higher than melanoma-related mortality, because you see it in elderly population. They have other systemic conditions that they die of. They don't die because of melanoma-related meds.
Just to continue on that, genetic testing on the tumor, like Dr. Katan was talking about, is helpful for prognostication. But there's also germline genetic testing, which we try to identify, families and patients who have a potential germline predisposition to ocular melanoma. The main gene with that is the BAP1 gene. And we would see an earlier age of onset of melanoma in those patients and potential other non-ocular tumors in those families and in those patients. So, yeah.
Adult hereditary cancer program, and a pediatric hereditary program. So if you have families in which more than one member apparently has cancer, and it doesn't necessarily have to be the same cancer, what we call cancer families. That's where you can refer these people, and we can look for genes which may predispose to cancer in families, and then initiate appropriate surveillance if they are positive going forward. There's a cost for everything, but yeah, insurance covers. Except, I mean, there insurance coverage for genetic counseling visits, everything's variable, but there is coverage for at least to some degree. By the way, Celeste is our representative at the state level. The greatest tendency is the bill in front of the state legislature to get licenses to get a counseling, which I hope will increase coverage, insurance coverage. Everybody writing was sending these on.
Thinking for an early diagnosis, how do we put together genetic testing with choroidal nevus? I mean, we see that all the time in the office and the primary care. So should we offer genetic testing to choroidal nevus patients that are not having any signs of growth or anything like that, but still suspicious?
I think that we should ask the good history in those cases. And if there's no suspicious family history of cancer, then I don't think that genetic testing would be helpful for those cases with just a nevus. I don't know, Dr. Katan, if you agree.
Lesion.
Sure. So what is new, or what's the most recommended way to follow these patients? I mean, we have a patient with a choroidal nevus. The traditional thing is just taking
Every 6
pictures.
months, a fundus photography and an ultrasound.
So still that's the
Yes, that's the gold standard. And then you have the mnemonic called as to find small ocular melanoma. So if the patient has features, if you have documented growth, then it's actually a nevi is it's converting. So as long as there's no growth, you keep following every 6 months.
Thank you.
I had a quick question, maybe this will be the last one. For Alex and then for our uveitis colleagues as well. In JIA, you hear different philosophies sometimes on what constitutes activity. I mean, if you look hard enough in some of these kids, you can see an occasional cell floating around. Some say one cell's too much, others, a few is not bad. What's your cutoff and approach when you see any activity going on?
It depends who you're talking about. If you're talking about your run-of-the-mill kid who's never had uveitis and comes in with a few cells, I'm going to be worried. If you're talking about one of those kids with chronic disease that's going on and on and on, I'll take a few cells. Long time ago, Steve Foster from Boston used to say, you got to have no cells. You got to have no cells. And I was at our Delphi meeting. I was sitting next to him, and he first went public and said, some kids are going to have a few cells. And everybody was quiet in the room. Like, what did you say? And that's when we learned that you can go to Imuran, you can go as high as you want, but some kids you just can't clear all the way. So I'm thinking about how long have they had uveitis, how under control they are, what treatment are they on. I'll tolerate it in some kids, but I won't tolerate it in others.
Do you modify your follow-up for those kids or?
Yeah, sure. A kid who's I'm going to see a kid more often. Now, I took out the slide with the AAP criteria for follow-up, and it's this complicated thing. It's hard to even read the chart. I would say a kid who's got JIA, who's never had uveitis, who's a girl who's ANA positive every 3 months to every 4 months. A kid who's had uveitis is going to be seen more often. A kid who's got cell lingering all the time, more often. A kid who's got chronic uveitis, they're by definition, they're going to have their pressure up and their inflammation up, down. I'll see them every 4 weeks sometimes.
I agree. I think the goal is always to try to get them quiet to no cells, but then you do have this very difficult to control subset of patients, their inflammation. It's just lingering. My goal for them is less than 5 cells per high power field, so less than 1+ cell. You know, if you can get them to trace, there's minimal damage that is done. I don't think we have good data of like trace cell for decades, what that would do, but I think that's safer. The lesser is better. And you know, I also have a population that's enriched for patients who are active and chronic, and so I'm seeing these patients every week, every 2 weeks, sometimes if they're in a flare, and at most if they're stable and quiet on their immunosuppression every 3 months. That's the farthest out I'll go.
Yeah, that's great. Thank you. I think we're good. Did you want to? Very good. Okay. Yes, we'll be back at 1 o'clock for the Snell lecture. Lunch is outside.